Topic for today's lecture is going to be lens-induced uveitis. So we'll start with the introduction. Lens-induced or phacogenic, which was previously called phacoanaphylactic uveitis, results from an immune response to lens protein following exposure to incomplete cataract extraction, trauma, or rarely capsular degeneration in a mature cataract. The most commonly encountered modern scenario is that of retained lens fragments following phacoemulsification, either in the posterior segment, after posterior capsular rupture, or zonular dehiscence, or an overlooked piece of nucleus or soft lens matter settling in the AC. This must be differentiated from bacterial endophthalmitis, which is usually more severe. Here in this histopathological diagram, we can see the lymphocytic infiltration, which indicates the inflammatory reaction to the lens protein, which are shown in white. Now, patient presents with the variable symptoms, pain, photophobia, redness, and blurring. But this is always associated with a history of recent complicated or uncomplicated cataract surgery, and uncommonly that of injury. Upon examination, there is granulomatous anterior uveitis, which may be mild, moderate, or severe. Corneal edema is common adjacent to an AC lens fragment. IOP is frequently elevated. Lens fragments may be visible in the anterior or posterior segment. Vitritis of variable severity is usually present, especially if the lens fragment lie within the vitreous cavity. Lens injury may be evident in cases associated with trauma. Now, patients present with his fair share of complication, or he may develop complications later on, which may include cystoid macular edema, glaucoma, formation of epiretinal membrane. Since the whole procedure, the whole pathology is based on immune reaction, rarely more severe sequelae such as retinal detachment and cyclitic membrane formation may occur. Investigations include OCT, B-scan, and biomicroscopic ultrasonography. Now, the most important part, the treatment, which includes number one, steroids. The route and intensity dependent on clinical circumstances. Number two is surgical removal of all lens material from the anterior chamber or via pars plana vitrectomy as required. Small lens fragment in the posterior segment can often be managed conservatively and will absorb slowly over months. Cycloplegia is given to make the patient comfortable, to discourage the formation of posterior synecdoche. IOP lowering treatment is always indicated. Penetrating or uncommonly blunt ocular injury should be managed concomitantly as appropriate, including removal of the damaged lens. So this concludes the topic of lens-induced uveitis here. Thank you.